Hello everyone, I am going to give you a presentation on my research paper, The Effects of Intensive Cardiac Rehabilitation Programs Utilizing the Pritikin Method of Diet, Lifestyle, and Exercise Modifications. I do want to create one footnote for you that I am a registered dietitian for a Pritikin intensive cardiac rehab at one of the facilities that will be utilizing the analysis of their outcome measures. So the abstract for this presentation is the purpose was to basically study and examine the progress along with contrast and comparison of the outcomes of patients with a documented cardiac event such as an NSTEMI, a stent, a coronary artery disease, perhaps coronary bypass, cardiac aneurysm, or a valve repair or replacement. And we're going to be reviewing the Pritikin plan and what that entails. And we're going to be looking at specific outcome measurements. It will not contain all of the outcome measurements that are typically used in an intensive cardiac rehab, but we'll be focusing specifically on blood pressure, weight and BMI, rate your plate, PHQ-9, blood serum lipid values, A1C, max METs, and the 6-minute walk test distance. So we're going to be reviewing data that was created by the AACVPR, which is the American Association of Cardiovascular and Pulmonary Rehab. This is a national registry that all cardiac and pulmonary rehab programs are required to self-report when it comes to patient measure outcomes. There is an annual accreditation that is required in order for you to be able to accept insurance for a cardiac rehab program. So what is Pritikin? Pritikin is the largest provider of intensive cardiac rehab in the nation. And there is a difference between intensive cardiac rehab, will be known as ICR, and then there is cardiac rehab, CR. So there is a very big difference. CR only is exercise, whereas intensive cardiac rehabilitation is lifestyle management, exercise modifications, and diet. So there's 36 sessions total. Each session is 2 hours long, and it is held 3 times a week. Each session contains 1 hour of exercise, which will have cardio, weight resistance, stretching, and then 1 hour of education. And typically you get one session is going to be a video, another session is going to be a cooking class, and another session is going to be some kind of a workshop seminar, mostly on nutrition, but also we do have some stress management, one session that's all on sleep, and we do have one session that is taught by our exercise physiologist. So the ICR team comprises of an RDN, several RNs, cardiac RNs, usually 2 to 3 at a time, and then we have a full-time exercise physiologist. So the diet recommendations for Pritikin, and these were created by Nathan Pritikin back in the late 1960s. And the diet recommendations are as follows. Vegetables, 5 servings per day, fruit, 4 servings per day, and a serving is a half of a cup. Calcium-rich food and beverages, 2 servings per day. Animal protein to be once a day, the rest of the protein sources coming from plant-based. And then whole grains, beans, starchy vegetables, nuts and seeds, 5 servings a day. And again, the serving is typically a half of a cup, with the exception of nuts and seeds, which is a 1/4 cup. The sodium intake is recommended to be between 12 and 1,500 milligrams per day. Alcohol is limited to 4 servings per week for women, 7 servings per week for men, and sugary beverages are encouraged to be limited. The lean proteins that are encouraged is skinless poultry, elk, venison, bison, and omega-3 rich fish. So one of the things that we'll be reviewing is the optimal blood pressure goals, which according to the American Heart Association standards set in 2017, ideal blood pressure is going to be systolic less than 120, diastolic less than 180. Lifestyle modifications will be anything from sleep, diet, stress management, and of course exercise. Medication adherence is strongly recommended, and the nurses on duty every day do discuss with the patients if they've taken their medications or if there's been any change to their medications. We also assess functional ability by the 6-minute walk test that's done at the initial first day of their sessions and their last day at the 36th session. Including, we review metabolic equivalent of task, also known as METs. It is established on their first day. They are provided goals throughout their session, and on a daily basis, the exercise physiologist is assessing their METs, and their METs are reviewed on the very last day as well. We also look at the American Heart Association recommendations on sleep, which is 7 to 9 hours. And we also look at cholesterol goals. We use serum lipid values, lab values. However, unfortunately, we don't always have those at intake, nor do we sometimes have those at their discharge. And this is related to a cardiologist recommendations and or it is regulated by their insurance company, how often they can get their cholesterol taken. Stress management is reviewed via several education sessions. And then, of course, we have Rate Your Plate, which is a copyrighted forum created by Brown's University that all Pritikin ICRs use and pay royalties to Brown's University to have that. The PHQ-9 is also known as the Ferens and Power, again, a copyrighted questionnaire, and that helps determine the level of depression of any patient. So specific objectives are basically to evaluate changes and or improvements of the patient from their initial first session to their last session, number 36, and then to also evaluate 3 different statistics. So we'll be looking at one program, which is the Renown Healthcare in Reno, Nevada, of which I am the RDN for. And then we're going to be reviewing statewide statistics for the state of Nevada. There are 3 programs total. And then we're going to be looking at the entire nation through the registry, consisting of 875 programs. So in this case, we want to review the body weight and BMI of the patients. We're going to be looking at their cholesterol, triglyceride levels, etc. Again, we're going to be reviewing any kind of stress management, ways that we can help reduce chronic stress, and teaching the patients the benefits of mindfulness, humor and laughter, social connections, mind-body techniques such as meditation or yoga. And they are receiving information as far as biochemical data, how to read their lab values, how to follow their diet if they are dining out, and any kind of therapeutic modifications for restoration of their cardiovascular health. So the methods that I am using for this research paper are via literature search, and I'm evaluating baseline at initial session 1 and at discharge session 36 for the patients in the Renown Healthcare Program, the statewide programs, and the national programs. And we'll be reviewing the analysis of all that data. So again, the assessments that I'll be reviewing today, but it is not necessarily limited to all of the assessments that an ICR does. We're going to be looking at age and gender, BMI, A1C, serum lipid values, metabolic equivalent of task, 6-minute walk test, the PHQ-9, which is the questionnaire for depression, and the Rate Your Plate. Others that we'll be talking about is medication adherence. There is a QLI questionnaire. We will not be reviewing it today, but it does help review and assess the quality of life index for the patient. Risk assessment we will review. Tobacco status as far as were they a previous smoker, are they abstaining, etc. We'll be looking at comorbidities, and race is often reported incorrectly, so it will not be assessed today. Through my research and pulling all these reports, I quickly found that race was being majority processed as unknown. This, of course, does actually hurt the research in general across the board, because we want to look at statistics for our Asian population, for our Hispanic population, for our African American population, for our Native American populations, etc. So we want to see what the statistics for those are. In addressing that with my nursing staff, I found that they felt uncomfortable asking these questions, and so this is something in my own program that is being addressed, and we are changing. So looking at some of the statistics, for example, this is the types of risk factors. So I have for Renown, for statewide, and for nationwide. So hypertension, 92.5% of Renown patients have hypertension. So we can see there 92.5, 89.9 for the state, and 79.8% for nationwide. So that's the amount of patients percentage-wise that we get into the ICR program that have hypertension. Hyperlipidemia, 89.5 for Renown, 86.8 statewide, and 81.7 nationwide. And again, these statistics are all self-reported to the registry, so there is a margin of error, but none that is reported. And for type 2 diabetes, for the Renown program, 24.8% of our patients have a diagnosis of type 2 diabetes. It is not including any pre-diabetes diagnosis. And I do want to point out that these risk factors or comorbidities as well are not as often documented as they should be. And again, it's another area that I reviewed while pulling reports that was not being accurately reported. So some of these statistic numbers on those risk factors may not be completely accurate, but that's the best that we had via the reporting. So functional ability of the patient is looked at by a 6-minute walk test, and we do the distance in feet. So at the beginning, on their very first day, they are given a 6-minute walk test where they're walking back and forth. At these, they have place stickers where they are supposed to turn around and go back and forth. Each distance is 50 feet long. And then at the very last day, on the 36th day, they do a 6-minute walk test. So here we're seeing what their progress was. So we can see, for example, looking at the national Initially, the average was 1,156.7 feet. And that was at the initial. At discharge, it went up to 1,451.2 feet. So they had an increase of 294.5 feet. That's national. Statewide, we can see the increase was 428.8. That statewide does include the Renown program. So I have just Renown by itself. Our increase was 390.8 feet on the average of their 6-minute walk test. Also, we look at MET, the metabolic equivalent of task. And so we have the initial and then the discharge. So for Renown, the initial is 2.6. This is based on the level of exertion the patient is utilizing during exercise. So at discharge, we see that it went up to 4.8 for the Renown group. So that's an improvement of 2.2. The goal for every patient from start to finish is to increase their METs by at least 2 points. Once they get to a metabolic equivalent task of 5, that is considered cardiovascular health. So I also have the attendance rate here. So we can see that the nationwide attendance percentage was about 89%, statewide was about 94%, and then my program at Renown was 99%. We are actually one of the top 5 programs in the country for attendance, for graduation rates, etc. The PHQ-9 is how we determine the level of depression of a patient. So PHQ-9, there are 9 questions that they fill out. Of course, the lower the score means the less depression the patient is exhibiting. So initial score coming in is around 5.1 for Renown and for statewide Nevada. For the nation, it's about 4.1. By the time the patient is discharged, our level has gone down by 1.9 points on the average for Renown, 2.4 points for statewide of Nevada, and 1.6 points for nationwide averages. So this we can see that the stress management that we are teaching the patients is working. So for BMI, A1C, cholesterol, and blood pressure, I don't have all of them listed here on the slide, but I will briefly review them. But BMI for the Renown group, this is for 133 patients over a 1-year period. So that would be November 1st, 2022 to November 1st, 2023. We saw 133 patients that completed the program. That doesn't mean we didn't have more patients. We often have patients that have medical events that prevent them from returning to ICR. So total discharged patients or graduated patients were 133. Initially, for males, they came in with an average of 29 BMI. For females, 27.8. At discharge, we had a change rate reducing their BMI by 0.3 for men and 0.4 for women. And that's pretty much across the board for all 3 of the statistics that I'm looking at. Group statewide, we had 189 patients total graduate. And again, that does include the Renown group. So there is 1 ICR at Renown in northern Nevada and 2 ICRs in southern Nevada, the Las Vegas area. And then we have nationwide 54,428 patients that completed the program between the time period of November 1st, 2022 and November 1st, 2023. So the others would be the A1C assessment. And for the A1C, of course, for prediabetes, that will be 5.7 to 6.4. And prediabetes is not measured in these statistical analysis. For diabetes, it is considered 6.5 and above. So for The initial for both Renown for Renown is 6.3%. For statewide and nationwide, it is at 6.4%, so very similar. And we saw a change of basically 0.2% for Renown and Nevada State and 0.1% for nationwide. When it comes to the cholesterol, the lipid values, we saw a change in total cholesterol between negative 12 points to negative 18 points. The majority of that negative 18 coming from nationwide, negative 12 from Renown. And again, the problem with the lipids analysis is that what we have seen at Renown, and I'm not certain about statewide or nationwide, is that not all of the patients do get serum lipid lab values before their initial first day or even by their discharge. And this is regulated by, most often, their insurance companies. For example, Medicare only allows for lipids to be drawn once a year, even if they are out of the norms, within normal limits. So this is a problem because we're not able to accurately see the results. For triglycerides, we're looking at change value of anywhere from 9 to 14 points lower. For the HDL, the good cholesterol, we're looking at anywhere from 1 to 3 points increase. And then for the LDL, our bad cholesterol, we're looking at anywhere from a 13 to a 16-point decrease. So this is showing some results, but again, I do hesitate to say that they are completely accurate based on the fact that we're not getting 100% reporting on that. Blood pressure, of course, is a big part of cardiac health. And again, the systolic is recommended to be 120 or less, the diastolic at 80 or less. And for blood pressure results, we found that there was a decrease of an average of 4 for the systolic, and 3 for the diastolic. And that was for Renown. For statewide, dropped 6 points for systolic and 4 points for diastolic. Nationwide, 5 points for systolic, 3 points for diastolic. So somewhat similar results. So let's look now at the discussion, looking at all of these statistics that were found. I do want to point out that the average age for male was around 70. For female was around 69. But the age range can go anywhere from the age of 18 to as high as 101. I personally have worked with a patient that was 98 years old. So seeing these older patients is a huge boost to find that if a 98-year-old can do these things, then so can someone younger than them. We do have patients. I've worked with a patient as young as 36 who came in with a cardiovascular event related to COVID. So it's not just our older patients that are coming in for cardiac rehab. There are many benefits to cardiac rehab. And of course, looking at the statistics for BMI, A1C, blood pressure, lipids, their functional capacity when it comes to the 6-minute walk test and the METs. We look at rate your plate, which is a determination of what their diet looked like before they come, and then what their diet looks like at the end of the process, and then the PHQ-9, which is their level of depression, is improving. So there are so many benefits in these statistics. And the diet, of course, is focusing on unprocessed whole foods and lean proteins, low fat, and getting a majority of our fruits and vegetables and other nutrients that are going to provide us with vitamins and minerals and antioxidants. Exercise, of course, is a big part of any cardiac rehab, but it is also a part of intensive cardiac rehab, in addition to the diet and nutrition that is emphasized. But as I mentioned earlier, insurance is can get in the way. We have some insurance companies that still consider intensive cardiac rehab an experimental program, although Medicare, thankfully, which is the largest of all insurance companies that we see for our patients, is on board with it. We also see that insurance, though, like Medicare, does inhibit how often we can do specific lab tests, which does reflect when it comes to getting accurate statistics. And then there's, of course, wait time. Wait time not only for how fast they can get into an intensive cardiac rehab program, but then also the wait time to see a cardiologist sometimes can be easily up to 4 months. Typically, after a patient has had a bypass surgery, they're not allowed to start the program until a minimum of 6 weeks after that surgery. However, my program alone has over a 60-day waiting period for someone to get in right now, because we typically see about 45 to 50 patients per day. And there's just basically a waiting list. So sometimes that wait list can prevent a patient from eventually wanting to come in. If they're scheduled 2.5 months out from their surgery, sometimes they just decide that they don't need intensive cardiac rehab anymore. But I would say 100% of the patients that I see that come in definitely are happy that they have come to the program and completed it, and they see a huge change both in their diet, their stress levels, and their commitment to exercise. So again, at Renown, for this 1 year that I evaluated from November 1st, 2022 to November 1st, 2023, I had 133 patients evaluated that completed the program. Statewide, it was 189 patients, which was a total of 3 programs, including the Renown program. And then nationwide, there's 875 programs, which incorporated 54,428 patients that completed the program. So I had quite a few references that I used for this, several other studies that have previously been done on Pritikin programs, as this program has been around, as I mentioned, since the late 60s. Also, I have provided a copy of my actual research paper, which also includes all of the statistics from the AACV-PR for all 3 Renown, statewide, and national. Also includes the PHQ-9 questionnaire and the Rate Your Plate questionnaire. So there's so much more on this topic that needs to be studied. And but from my personal experience as an RDN with cardiac rehab, I teach cooking classes, I teach nutrition classes, and I have seen patients come in begrudgingly being there. They tell me straight up they're not going to change their diet, and then by the end they have done 100% turnaround when it comes to their diet. I had a patient that was a dialysis patient, and not too many of them actually last the full 36 programs, and he was one that told me when he first came in that he wasn't changing his diet. And by the end, I actually ran into him at a Sprouts grocery store, and he was eating, shopping for beans and low-fat foods and fruits and vegetables, which was completely 100% opposite of what his diet was before he came in. So I have seen remarkable results, and really what I have seen most of all is that these patients are reducing the stress in their life. They're creating social groups where they create walking groups. Once they've graduated, they create luncheon groups, so they make friends while they're there, because these are people that have all experienced some kind of a life-changing heart event. And really the accomplishment that they feel once they have completed the program, not only in just how they feel as far as their physical awareness, but their mental awareness is completely a big change as well. And it's really such a positive environment to see all of these amazing changes. So cardiac rehab is something I knew nothing about before I became a dietitian, and now as a dietitian in an intensive cardiac rehab, it's all I want to do as my future pursuit, because it is a really fun job. All right, thank you for your time.